Muy buenas tardes. Tenemos el honor en el día de hoy de estar acompañados por la doctora Nikki Karavitaki en este encuentro con el experto. La doctora Karavitaki es una experta internacional en enfermedades de la hipófisis y nos acompañará el día de hoy en esta presentación de casos clínicos. Muchas gracias, doctora Karavitaki, por estar hoy aquí. Y bueno, tendrá ahora una presentación a cargo de la doctora Natalia de Ligianis.
It's my pleasure to present our special guest, Dr. Nikki Karavitaki, who is a senior clinical lecturer in endocrinology at the University of Birmingham and an honorary consultant endocrinologist at Queen Elizabeth Hospital in Birmingham, where she co-leads the pituitary service and pituitary multidisciplinary team since 2015. She is originally from Crete, Greece, and she completed her training in endocrinology, diabetes, and metabolism in Athens. She had been previously awarded a master's degree in neuroendocrinology from the University of London. She moved to Oxford, where she became a research fellow in clinical neuroendocrinology. She got her PhD from the Department of Experimental Physiology in Greece. She worked for 9 years as a consultant endocrinologist in her area of expertise, which is pituitary disease, together with Professor Ashley Grossman at the Oxford Centre for Diabetes, Endocrinology and Metabolism, and also as an honorary senior clinical lecturer in endocrinology at the University of Oxford. She was also a fellow of the Royal College of Physicians and a member of the Association of Physicians of Great Britain and Ireland. She has more than 150 publications and more than 10 of them during the last year. She participates as a lecturer in national and international meetings. She is a member of various endocrinology and neuroendocrinology committees and societies. Her current areas of research are long-term morbidities and mortality in pituitary disease, aggressive pituitary tumors, adverse effects of radiotherapy for pituitary tumors, quality of life in patients with pituitary adenoma, and pathogenesis and biomarkers in pituitary tumors. Some of the people in this photo are part of her pituitary team, and she also supervises fellows and trainees from all over the world. I would like to add that I had a great opportunity to get to know her during my observership in Birmingham 2 years ago, where I could see how valuable she is not only as an expert but also as a person.
Okay, so hello everybody. I guess I should still say good morning to you. Here it is 2 o'clock in the afternoon. It is a real pleasure for me to share this 1 or 2 hours with you. And many thanks for the kind invitation. Due to the COVID-19, obviously, we are not in a position to have a face-to-face interaction, which I would love, knowing the warmth and the kindness of Latin American people. But there you are. We have the technology which will allow us still interact and share knowledge and experience. So my talk will focus on non-functioning pituitary adenomas. And over the years, when I was in Oxford and then when I moved in Birmingham, we did, I would say, a quite significant amount of work on these tumors, which, although they are non-functioning and silent, I still think that they are not boring, and we have a lot to learn, and these tumors have a lot to teach to us. So this is the outline of my talk. What I will cover is their definition, their epidemiology, how do they present, how do we diagnose them, how do we manage them, and then some conclusions. So what are non-functioning pituitary adenomas? These are benign pituitary neoplasms, which, as we all know, arise from adenohypophyseal cells. They are not associated with any clinical evidence of hormonal hypersecretion, so they are clinically silent. And the mechanisms of silence, they are not clearly defined. In terms of immunostaining, there is a variety. They can stain for every hormone or combination of these. And just to remind you, the relatively recent WHO classification of pituitary tumors, to remind you that now we are also using not only the hormone staining to characterize them, but transcription factors. And as I mentioned, the non-functioning pituitary adenomas can have staining for various hormones or combinations. And the new entities that then what we used to call null cell adenomas, before, which belong to the Anaphase, before we put these statements, we need to make sure that they do not stain for any transcription factor. So that's the relatively new information from the WHO classification. And it is important, I think, that labs, pathology labs, introduce the use of transcriptional factors if they haven't done already. Now, in terms of epidemiology, I will start with a relatively old publication. This was a meta-analysis by Sherin Azad in 2004, in which they looked at post-mortem studies and radiology studies. And they looked at the prevalence of pituitary lesions, which most of them should be pituitary adenomas. And I would have thought that most of them should have been non-functioning pituitary adenomas. So what the numbers showed? They showed that in post-mortem studies, the reported range was between 1 and 35%. On average, this was around 14%. On imaging studies, the rate was between 1 and 40%. On average, around 23%. I think this number is a bit generous. It's probably too much nowadays. And generally, we have this rule of thumb, around 1 in 10 people could have something detected in their pituitary if they had brain imaging for an irrelevant with pituitary reasons reason. What is interesting, I think, from these studies, the post-mortem studies, is that the prevalence of macroadenomas was around 0.20%. And what does this mean for me? It means that probably most of the macroadenomas would have been detected during the lifespan, would have grown or been detected. So let's keep this in mind. Now, when we talk about epidemiology, of course, the best way to identify how common a tumor is and what is its incidence is by doing proper population studies. So go to a well-defined population and see if the healthcare system allows or if the records allow how many patients have a specific tumor. And we did this in Oxford many years ago with Alberto Fernandez, a fellow we had from Spain. And Alberto went to the area of Banbury, which had a population of 85,000 people. And as you know, the healthcare system in the UK allows us to do such studies because the vast majority of the patients are registered with a GP service and their records, a general practitioner. So the records are there. And we found that the prevalence of non-functioning pituitary adenomas was 22 per 100,000. So this is a number that happened to be present in the UK. In terms of rate, most of them were men. The median age of diagnosis was 52. Women were younger, but still the age of 50s is a young age nowadays. And the duration of symptoms was around a year, but we can see that there was a wide range. In terms of how common they are compared with other tumors, it seems that they are the second most common pituitary adenomas, and prolactinomas dominate. And this makes sense because in older series, when they looked at hospital records, they claimed that Anaphase were more common, which is not the case, because in hospitals, in pituitary centers, we would have mainly, especially in neurosurgical centers, we would have seen mainly Anaphase rather than prolactinomas, because these patients have more probability that they will be operated on. So we keep this number. And how does this compare with other areas around the world? And I'm giving you population studies, so studies which are more robust to define the epidemiology. So in Belgium, 14 per 100,000, in Finland, 25 per 100,000, in Malta, 26 per it's 100,000 actually here, one extra zero. And for Canada, 41 per 100,000. So overall, between 20 and 30 cases per 100,000 people. So just go to your catchment area, to what your hospital covers, and see the population, estimate the population, and then you can have a rough idea on how many clinically relevant Anaphase, non-functioning pituitary adenomas you would expect. And an interesting point that came from a study in Finland was that as people get older, the incidence of Anaphase increases. And a more interesting point from this study was that when they grouped the patients in two periods, so the early period and then the later period, they found that the standardized incidence ratio of Anaphase was more or less similar, or we should say not significantly different between the two periods. But when they looked at the incidentally discovered adenomas, the ones that were picked up at the second period, at the later period, were significantly higher. And of course, this has implications. It means that with the advances of the imaging techniques and with the more use of brain imaging, we pick up more such lesions, and this has implications in the healthcare system and in some occasions on the patient's anxiety. And now let's move on the presentation. It is basic knowledge from our first years in medical school or even our training year. We tend to look at such diagrams. So how do they present? They can present with mass effects, or they can be found incidentally. Mass effects, it can be easily extracted. If you look at the anatomy of the pituitary gland and what structures are around. So what we would expect could be hypopituitarism because of pressure to the normal pituitary, headaches, visual field defects or reduced visual acuity, issues with the cranial nerves, which are in the cavernous sinus, very rarely hypothalamic damage, and very, very rarely seizures because of extension in the temporal lobe. What we had found in a population study is that apoplexy had a prevalence of 6 cases per 100,000 people. And this is a diagram I tend to use when I teach medical students, which shows what to expect usually when we have a pituitary tumor compressing the optic chiasm. Now, how are we going to put the diagnosis for these tumors? Obviously, when we have pituitary imaging, which shows a lesion there, which looks like an adenoma, we need to assess the pituitary function and make sure that it's a non-functioning pituitary adenoma, so it doesn't hypersecrete hormones, which could cause a clinical picture. And importantly, we will need the pathology to tell us that this was indeed an adenoma. And then with the help of the hormonal assessment, we can confirm that this was a non-functioning pituitary adenoma. An important point, I think, in clinical practice is the differential diagnosis from a prolactinoma. And when I was a trainee, I was reading in books that, and this was from series published in the late 80s, was that if the prolactin is above 6,000, then, and we have a macroadenoma, the lesion is a prolactinoma. If the prolactin is between 2,500 or less than 3,000, and I don't know, probably you have different units in Argentina, you divide it with 20 to see your units, then most likely an NFA. And then we have this gray zone between 3,000 and 6,000, which could be an NFA or a prolactinoma. And it is important to know as to whether this is a prolactinoma, because as we all know, the management is different. For a prolactinoma, we would go with medications. For an NFA, we would go with surgery. So this is what I had been taught when I was a trainee. And in my sort of first years in Oxford, where I worked under the mentorship of Professor John Wass, we did a project. We did a project looking at the prolactin values in non-functioning pituitary adenomas, which had shown suprasellar extension. And these tumors were confirmed because histologically confirmed, pathologically confirmed because they had surgery. Amongst these patients, 41 were on medications that could increase the prolactin, and we found high prolactin in 39% of the patients, and importantly, prolactin above 2,000 in only 1% of the total group. And when we looked at patients who were not on prolactin increasing medications, then only 0.5% had prolactin below 2,000. And for us, with this study, we redefined the cutoffs of prolactin when we are trying to differentiate between a prolactinoma and the non-functioning pituitary adenoma. And we went further because we wanted to see if indeed this value, this cutoff, can be confirmed in other tumors like craniopharyngiomas or Rathkes, which had suprasellar extension and they could cause high prolactin. And again, we found that high prolactin, prolactin above 2,000, was in 1% of those not on prolactin increasing drugs. And these are the assays that had been used over these years when the patients were followed up by us. So we were pretty certain now that the disconnection hyperprolactinemia related with a tumor, and here with an NFA, it should very rarely be above 2,000 or 3,000 milliunits per liter if we use these assays that I'm showing you, which I think mostly are used mostly in many parts of the world. Now, another way to put the differential diagnosis is to have a trial of dopamine agonist. And what we would look at the time until we achieve normal prolactin. In disconnection hyperprolactinemia, a dopamine agonist would cause a very dramatic, very quick reduction in the prolactin. Prolactin, as we know, has a very short half-life, whereas in an adenoma, this would definitely not happen within 1 or 2 or 3 or 4 days. And we could look at tumor shrinkage, which of course is more common in a prolactinoma rather than a non-functioning pituitary adenoma. So that's about the diagnosis. Now, let's move on to management. Management options could be observation, could be surgical removal combined or not with radiotherapy, could be medical treatment. And I will mainly focus on the first two because these are the areas where we have most of the data, published data. Now, in Birmingham, we have set up a number of guidelines which give us some sort of guidance on how we manage our patients so that we all speak the same language when we see the patients in the pituitary clinic. And we have our NFA guidelines. And the general comment we have put in the first page of these guidelines is that the management of these patients will depend on the size and extensions of the tumor, on the presence of visual compromise, on the proximity to the optic chiasm, on the age, comorbidities of the patients, pituitary function, and of course, fertility plans. So the management plan should be individualized. It's not that all NFAs will go for surgery or all NFAs will have observation or after surgery, all of them will have radiotherapy or whatever. So let's start the journey with the observation, what the data show. This is a study, small study we had published when I was in Oxford with presumed microadenomas. And we found that at around 5 years follow-up, the probability of increase in size was around 19%. And actually, I remember these patients, when the tumor increased, it was minimal, it didn't cause any problem. We had found that sex and age at presentation were not predictors of enlargement. And if we look at more studies on microadenomas, which we assume are micro non-functioning pituitary adenomas, this is a nice paper from Mark Molich, published 3 years ago, in which they collected the cases of presumed microadenomas, micro-Anaphase, and they showed that the percentage of enlargement was 10%, of decrease was 7%, and the vast majority of the tumors remained stable. We have to keep in mind, of course, the years of follow-up, which is quite variable, starting from 1 to 8, and in most of the cases was around 3 or 4. And this has to be kept in mind. So we don't have data with very long follow-up for these patients. If we move on to macro-Anaphase, again, the data from our Oxford study, in which we had shown that at 5 years follow-up, around 50% of the patients showed enlargement of the tumor. And of course, this was a selected group of patients who did not have surgery for usually various comorbidities. What we had also found was that new or worse visual field defects were present in 67% of the macroadenomas, which showed enlargement. So the message from that study was that around half of the patients in this series, during 5 years, they would show tumor growth, and obviously a number of them would require intervention. Sex, age, visual field defects, cavernous sinus invasion at presentation were not predictors of enlargement. And if we go to the Molich paper, in which they collected again data from a number of macroadenomas, it was shown that enlargement was in 23% of the cases, reduction in 12%, and no change in 65%. Again, the follow-up ranges, but still it is not massive. I would have thought that the mean follow-up here would be around 3 to 4 years. So again, we need long-term data. A meta-analysis around 10 years ago, looking at the event rate of tumor growth per 100 patient years, showed that in macroadenomas, this was around 12, and in micros 3, significant difference. And the message is that probably what we all expect, the probability that a macroadenoma will continue growing is much higher than a micro. It's not a surprise, we expect that, but it was shown with appropriate statistics. And in this group of patients, apoplexy was very rare, 1 event per 100 patient years. And I'm putting this data because occasionally we come across patients who have been referred to us with a macro Anaphase, so above 1 centimeter. The tumor is far from the optic nerve. We tell them, you don't need an operation now, at least now, but the patient comes with literature or what they have seen on the web saying that they are under risk of apoplexy, and this could be lethal for them. So these are the numbers for the apoplexy rate. Now, a very, very interesting study by Jürgen Honegger from Germany showed that the tumor volume doubling time is between 0.8 to 27.2 years. What does this mean? It means that we cannot predict the behavior of these tumors. The tumor may enlarge within a year, within 2 years, 3 years, whatever, and even cases after 27 years have been reported. And this makes very difficult to have protocols and algorithms on how to monitor these patients. So what we've done in Birmingham, and this is from our guidelines, when we have a tumor referred to us, which looks like an NFA, after, of course, this is confirmed by physical examination, history, of course, anterior pituitary hormone profile, and definitely we would do vision, and we would have the pituitary MRI. So if this tumor is a microadenoma below 1 centimeter, we go with pituitary MRI at 1 and 2 years. 5 years is a bit of debate. To be honest, more we added this because of anxiety rather than evidence, but still we don't have evidence on that. If the tumor is a macroadenoma above 1 centimeter, if there is visual deterioration or the tumor abuts the optic chiasm, we will discuss the case in our pituitary MDT. If this doesn't happen, so if it is far from the optic chiasm, we would go with surveillance and we would do a scan in 6 months and then yearly for 5 years. And then after that, we would extend the period of observation. But again, I think nobody knows how often we should do this, what is a cost-effective protocol and what is a safe protocol. If the tumor causes problems with the vision, is close to the, is abutting the optic chiasm, we would most likely consider surgery, but we would take into account the age and the comorbidities of the patient, and we would discuss this with the patient. We have cases in which the tumor abuts the optic chiasm and we don't operate on because we want to buy some time before a patient undergoes an operation, particularly if the pituitary function is normal. So it is individualized, but more or less, this is the protocol we follow in Birmingham. And speaking of protocols, this is a case we had of a patient, a male, who presented with what seemed to be a non-functioning pituitary adenoma. 2013, we scanned him. In 2015, it seems that something is happening. In 2017, the tumor is very close, is going actually upwards, trying to touch the optic chiasm. We had a discussion with the patient. We offered him the options, and the patient was keen to have surgery, to be honest. And just before the surgery, we did another scan, and you can see that the tumor regressed, which actually is a big lesson that, yes, papers and literature is useful, but finally, each individual case has to be dealt in an individual way. And of course, it is important to do a scan very shortly before the operation so that we know the status of the tumor. So that's about observation. Now let's move on to management after surgery. We have a non-functioning pituitary adenoma. Our surgeon took out as much as he could. And then the question is, what next? Are we going to monitor this patient? Are we going to offer radiotherapy? Are we going to consider something else? And I have to remind you that there are no randomized controlled trials on the use of adjuvant radiotherapy. And my feeling is that probably this is not practically feasible. Oops, sorry. Okay, so let's see what the data show. Oops, sorry. Does it move? I'm not sure if it has frozen. Oh, there we are. Oh, sorry. Let me go. Ah, yes. Okay, it moves. So I have a few studies here, which I chose because they give probabilities of regrowth. They go with Kaplan-Meier curves, which is the right way of approaching the topic. And before I give you the numbers, I want to remind you a secret that all of us know, but quite often it escapes from our attention. We need to compare the most recent scan of the patient with the previous scan. Yes, that's good, but also with the first or second post-operative scan. I'm sure we have all fallen in the trap of having a patient who had surgery. We do a yearly pituitary MRI, and our radiologist compares with the previous year. In his eye, it doesn't seem to be a difference. But when we have serial scans of 10 years and we go to the first and then last scan, we see a difference of 1 or 2 centimeters. So please remember that. It's very, very important so that we pick up early, at an early time, growth of the tumor, regrowth of the tumor. Now let's go to the data. These are cases with radiotherapy, so recurrence rates at 5 and 10 years, and this is without radiotherapy. No doubt that radiotherapy reduces the probability of regrowth. This is a fact. We know that. And if we look at various types of radiotherapy, older series with conventional radiotherapy, they give control of 98, 96, 93, 88% at 10 years, so good optimal data. If we look at the fractionated stereotactic radiotherapy, again, control rates excellent, 100%, 88%, 98% at 5 years. And if we look at stereotactic radiosurgery, again, more or less similar results, similar controls of the control rates of the tumor. Median dose 16 gray in this series, so lower than what we offer for functioning adenomas. Of course, we have to keep in mind the late toxicities of radiotherapy, particularly hypopituitarism. But just to remind you that this series are a little bit biased. We have selected populations which would have small tumors, and predictors of response in this series have been shown to be small tumor volume, below 5 centimeters in the third, and limited supracellular extension. So it's a well-defined patient population here. So, as I mentioned before, there is no doubt that radiotherapy has a good, positive impact in controlling tumor growth. Are there any factors, any other factors that could make us think that we can have another parameter to predict the outcome? And these are two studies here. One is from Ireland, the other was again at my times in Oxford, where we showed that what defines the further growth of the tumor is the extent of tumor removal. So the best summary is here. And what we had shown, and the other colleagues in Ireland, is that if there is extracellular remnant, the probability that the tumor regrow in 10 years is around 80%. So this is recurrence-free, so I go with a probability of regrowth. If it is intracellular residuum, in around 50% of the cases, at 10 years, we will have tumor regrowth. And if there is no residual tumor, so if there is a good clearance, the probability that at 10 years follow-up, the tumor will grow is 6 or 0%. So the extent of tumor removal does play a role. And this is important to discuss with our surgeon. We need good surgeons. We will try and do as much removal as possible, of course, thinking also the safety of the patient. We don't want adverse effects following an operation. So the post-operative, as we said, imaging is important, showing what type of removal we have. But of course, this will be affected by the experience and intention sometimes of the surgeon. Some surgeons do not want to be aggressive, and by tumor invasion. If we have a tumor which, for example, invades the cavernous sinus and it is CNOSP 3 or 4, yes, no surgeon will go in that area and try do complete tumor removal. However, persistence of the post-operative residual tumor is not always associated with progression. So we may have residual tumor and it remains stable over the years. And what does this show? This indicates that additional risk factors need to be considered, and there is research going on this topic. And I think we are still trying to identify factors and use them in our clinical practice. So what do we do in Birmingham? If we have surgery and there is no or intracellular residuum, we go with monitoring. We do a scan every year for the first 5 years, then later every 2 to 3 years. If there is extracellular residuum, we bring the case in our pituitary MDT. We take into account the age, the comorbidities, the pituitary function, fertility plans, and what do we have on the plate? We can do observation, we can offer radiotherapy, or even repeat surgery. And again, as I mentioned, this is individualized. If we go for observation and radiotherapy, we continue the imaging with yearly scans for the first 5 years, and then later we reduce the frequency. If there is regrowth after this, so extracellular residuum, we offered something and the tumor comes back, then the case is individualized, and I will show you some data in a minute. I just want to point out that, yes, radiotherapy is useful. However, we have useful in controlling the tumor, but we have to do risk assessment, Okay, and again, we have to take into account all these factors before we decide on radiotherapy. And for the primary NFA, if there is extracellular residuum, we could sit down and discuss radiotherapy, although my preference would be to have a surgeon who removes safely as much as possible. If there is recurrent NFA, radiotherapy is useful, and we had published this data when I was in Birmingham, showing that radiotherapy alone or radiotherapy and surgery seem to offer better outcomes rather than monitoring alone a regrowth. And I will give you more data in a second on that. A further point. You remember this slide a couple of minutes ago with the data showing the regrowths at 5 and 10 years after surgery. What we notice is that the longer follow-up, the more regrowths we pick up, which means that we should never discharge these patients. And these are some data we had published in which we showed that around 20% of the regrowths were picked up after 10 years of follow-up. And this is actually a patient we had who presented with this lump 18 years after the original operation. What is interesting is that if we are talking about regrowth, this will be detected much earlier if the tumor, the residual tumor, was extracellular, or later, much later, if the remnant after surgery was within the cell. And then here is a study, we published this in 2019. This was a meta-analysis. There is so much discussion on silent corticotroph adenomas. Are they more aggressive? Do they show more recurrence rates? And we collected the literature very, very carefully. And my colleague and fellow Dr. Funtas and the other co-authors, they did very, very meticulous work on looking at the series. And we found that at least based on what is published, silent corticotroph adenomas did not have a higher risk of regrowth compared with other non-functioning pituitary adenomas. And I'm not saying that this is right or wrong. What I'm saying is what the literature, what the evidence showed. Having said that, of course, there is a group of silent corticotroph adenomas which can be aggressive, and we don't know why. I think, though, that this is a minority, and we should not put in the same basket all silent corticotroph adenomas and say that these are aggressive tumors, and therefore, after surgery, we need to irradiate them. A further question, what is happening after apoplexy? And we had published some data 10 years ago on patients who on the background of a non-functioning pituitary adenoma, they had acute pituitary apoplexy. And these patients had only surgery. We followed up for a mean period of 79 months. And we found that at 5 years follow-up, the regrowth rate was 13%, 13%, which of course is much lower than what we would see in other non-functioning pituitary adenomas, which did not present with apoplexy and had surgery. But this study clearly shows that apoplexy does not kill the tumor, and we have to be alert and monitor the patients for lifelong. Another point, and this is a study I had the opportunity to do when I moved in Birmingham, and I collaborated with Oxford because that was the best way to collect numbers. So the question is, what is the best approach in a tumor, an NFA, which has shown regrowth? All the data, all the series say we have a tumor operated on and then regrowth rate this and that and that. My question is, what next? What am I going to do for this patient? So what we showed, and we had 230 something regrowths, which is, I think, a quite large number. So we showed that in the total group, a second regrowth appeared in some patients, and the second regrowth rate at 5 years was 35%, and at 10 years, nearly 50%. I think the most important message, though, from that study was that if we opted for monitoring of the first regrowth, so we have an NFA operation, the tumor grows, and then we decide to do nothing, or I should say to monitor. What we found was that at 5 years, 63% of these patients showed more growth, and at 10 years, this went to 82%. So a tumor, we are dealing with tumors which have manifested their behavior of growing more and more. And in our series, we found that around 35% of this group eventually were offered an operation, either because the tumor was continuing growing or because it was causing visual deterioration. Definitely not all the tumors which continue growing will need an operation, but just bear this in mind when you see your patient and when you are trying to take a decision which will rely on data. Then how about the third regrowth? And I think this actually defines the really aggressive tumors. We found that amongst those who had a second regrowth, a third regrowth appeared in 26%. And overall, if we opted for monitoring, again, there was a high probability that continuous growth will be there. Malignant transformation in this very large series of patients was found in 2 out of 237 patients who had regrowth, representing 0.8% of the cases, and one was a gonadotroph adenoma. This is a Birmingham case. The patient, although still has metastatic disease, nearly 20 years later, she's well, whereas this case was a silent corticotroph. We had it in Oxford, which actually became overt Cushing's, and unfortunately, the patient passed away. So I gave you some data. I shared with you some experience we have with on non-functioning pituitary adenomas. And this is from a preface we did with Maria Flesheriu, my friend and colleague, in which we put the title, Non-Functioning Pituitary Adenomas, Not All the Same and Certainly Not Boring. And I hope I managed to convince you that they are certainly not boring. We can start from this, we can have this, or we can even have this, which is a patient who crossed our door 1.5 years ago, and we still have dilemmas on how we should manage her. So conclusions. The prevalence of Anaphase is between 14 to 41 cases per 100,000 people. Look at your population, look of what to expect, and there is definitely increase in the incidence of incidentalomas, and these are points we need to take into account when we provide care for these patients. Based on the currently used assays, the prolactin cutoff of around 3,000 milliunits per liter, so you divide it by 20 for your units, is good for the differential diagnosis from a prolactinoma. If we opt for observation, the risk of enlargement is not clearly defined because of the heterogeneity in the studies, but definitely it is higher in the macroadenomas, which of course require close monitoring. How long are we going to monitor the patients for? And what are the predictive factors of enlargement still remain unknown? And if we see increase in size in such a tumor that we monitor, the management plan should be individualized based on factors I previously mentioned. And then following surgery, we have to remember that there is lifelong risk of regrowth. So we do not discharge the patients. And this is affected definitely by the extent and location of the residual tumor. Radiotherapy reduces the risk of regrowth, but its use should rely on a holistic risk assessment. Then how about the aggressiveness of specific histological subtypes? I gave you a flavor on silent ACTH adenomas. My feeling is that we need methodologically robust evidence, large studies, large sample size with good follow-up to give outcomes. We have to remember that after apoplexy, we cannot be relaxed. The risk of regrowth is still present. And I gave you some data on the risk of multiple regrowths or continuous growth and the impact of management approach, and particularly if we opt for monitoring. For those who would like to have a little bit of more reading, we had done with Maria Flesheriu a special issue in the journal Pituitary on Anaphase. This was in April 18. I think it still has useful data. despite being 2 years ago. And for those who would like to have some more information, I think there are interesting papers there, interesting articles from well-known experts. Before I finish, I would like to thank our Birmingham pituitary team. This is an amazing team, and Natalia, Florencia, Paula, who came, I think they had the taste, the flavor of this. We are a large team, and we all work together for the benefit of the patient, and we are trying to be as much innovative as we can be, but again, having in the center of our mind the patient. So I would like to thank you very much for your attention, and I would be delighted to answer any questions that you may have. Thank you very much.
Thanks, Nikki, very much. Very interesting, very nice talk. Thanks. We enjoy it a lot. Questions? I have one. As regards in clinical practice, as regards the comment of Ashley Groffman of whispering tumors, in the case of non-functioning tumors, macroadenomas, we check obviously for hypopit, and the question goes to hypersecretion, non-functioning, clinically nothing. What would you check for growth hormone excess, and especially Cushing, hypercortisolism? What would be the most effective and most economic test to do if you do?
Yeah, in all patients, we do an IGF-1, all patients with a newly presenting pituitary tumor, which looks like an adenoma, or even if it is not an adenoma, we would do an IGF-1. And this will be our screening test. If IGF-1 is normal, we stop there. Obviously, we examine the patient, we see for picture, but in a whispering tumor, I doubt if we would have a very robust clinical picture. For Cushing's, that's a good question. I have to say that in Birmingham and when I was in Oxford, we relied on the clinical picture. We did not do, let's say, 24-hour urine-free cortisol or an overnight dexamethasone suppression test. We used to rely on, and we still do, on the clinical picture. We haven't come across problems with that. And I will share with you the practice I had when I was in Oxford. Here in Birmingham, I don't do it anymore. If a tumor post-operatively, if a macroadenoma was operated on, and then we had the pathology report, which showed staining for ACTH, I used to do an overnight dexamethasone suppression test for these patients, post-operatively, just to see if I have missed anything. And I also used to do it every year in a number of patients. And I never picked up a problem. I never picked up Cushing's, but exceptions exist. And I think the question is that we need to be cost effective. And I don't know how cost effective would be to investigate biochemically with biochemical tests for Cushing's in every patient with a non or a presumed non-functioning pituitary adenoma. So coming back to the question, the clinical picture would guide me. Whether it is right or wrong, time will show. So far, no problems.
Okay, perfect, thanks. Another question is macroadenoma in women, pregnancy, not impinging the optic chiasm. At the time of delivery, would you suggest cesarean or vaginal delivery?
Okay, this is a question we have from our obstetricians. Obviously, if the tumor is far from the optic chiasm from the very first beginning, we tend to recommend vaginal delivery, and we don't have many cases. I mean, you can imagine this is a rare scenario, a woman with an NFA, which has not affected her fertility and becomes pregnant, etc., etc. But until now, we went with vaginal delivery, and there were no issues. And every time, I have to say, despite this suggestion, every time the obstetricians come back to us and ask again and again.
Okay. And I don't know if it's the question. My last question is, you said that if you have a macroadenoma contacting the chiasm and normal pituitary function, perhaps you would adopt an expectant management. Is that?
Yes, I mean, there are cases that we do that. For example, if we have a woman who is 45, okay, 40, not 45, let's say 40, 38, and she doesn't want to have any problems with her pituitary function for whatever reason, we say, let's wait. Or if we have an 85-year-old man with a tumor which is not causing, it's not compressing the optic chiasm, and pituitary function is normal, why should we operate? Of course, the argument is the other way around. Why do you want to operate on him when he's 90 and has problems with his vision? There is no right or wrong. It's individualized, but we do discuss this option. And we have a number of patients, and we are collecting this series now, who had tumors close to the chiasm and refused, or we more or less pushed for no operation. And it is an approach.
Well, good afternoon, Nikki. We will start in Spanish. Bueno, el primer caso es un paciente de 14 años, al igual un paciente masculino de 14 años, al cual se le diagnosticó un tumor, un adenoma no funcionante, en el contexto de cefalea, falla en el crecimiento y también alteraciones visuales. Sus antecedentes personales es que tuvo una torsión testicular en el año 2002, donde tuvo que realizarse una ortofuneglectomía izquierda, y no tenemos antecedentes familiares, ya que el paciente era adoptado. Con respecto al examen físico, estaba hemodinámicamente estable, con un índice de masa de 19, tenía una distribución del vello masculino con un Tanner 4, un testículo derecho de 25 mililitros, un escroto pigmentado, y también un pene adulto con Tanner 5. Con respecto a los antecedentes, en el año 2008, en el contexto de falla en el crecimiento y alteraciones en la visión, se observó un adenoma de 25 por 20 por 21 milímetros. Vamos a observar también un componente quístico superior, que también lo podemos elaborar en estos cortes. Y con respecto a los ejes, tiene una prolactina de 57, que podría estar elevada por el efecto del tallo, un perfil tiroideo, un eje tiroideo normal, FSH y testosterona disminuidos, y GF1 disminuida, y también un cortisol de 6.8. En este contexto, al paciente a los 15 años se realiza la primera cirugía transeptoesfenoidal, una inmunohistoquímica que mostró positividad para FSH y LH con un P67 del 1%, hubo una resección de más del 80% con campos visuales normales posteriores a la cirugía. Se recuperaron los ejes gonadales y corticotropos y se inició tratamiento con levotiroxina por un hipotiroidismo central. Vamos a observar 4 meses postquirúrgico, hay una lesión de 10 por 10 milímetros. 3 años posterior a la primera cirugía, el remanente progresa siempre con campos visuales normales. Vamos a observar la lesión con los cambios con respecto a la lesión anterior. Entonces se sugiere una segunda resección transeptoesfenoidal, donde la inmunohistoquímica vuelve a mostrar positividad para FSH y LH con P53 positivo en más del 50% del material histológico y un Ki67 del 3%. 15 meses posoperatorio con esta resección que fue menor al 50%, un campo visual normal. Se decidió iniciar con cabergolina subiendo dosis de hasta 4 miligramos y seguía el reemplazo con levotiroxina de 75 microgramos con una lesión que medía 19 por 17 milímetros. En el año siguiente se decidió aumentar la dosis de cabergolina hasta 6 miligramos y permaneció estable imaginológicamente sin clínica oftalmológica. Y como un resumen de los años, sobre todo el segundo periodo postoperatorio, la segunda cirugía en el año 2013, las imágenes permanecieron estables. Podemos observar que los diámetros fueron de 19 por 17, 21 por 19, 20 por 24, y así se mantuvieron en los últimos 4 años, bajo tratamiento con cabergolina 6 miligramos, con campos visuales normales y también con un OCT que fue normal. El paciente quedó con secuela con el déficit reemplazado con levotiroxina. El paciente inició un seguimiento con nuestro hospital desde el año 2017, 4 años después de la cirugía. En el año 2017, cuando nosotros lo evaluamos, se había considerado la radioterapia, pero el radioterapista se negó por el contacto que tenía esta lesión hipofisaria con el quiasma óptico. Y para la discusión, ¿cuál sería la mejor opción ahora que el remanente del tumor está estable, que no hay alteraciones visuales, pero que la lesión contacta el quiasma óptico en un paciente de 25 años bajo tratamiento con 6 miligramos de cabergolina? That was the first question. If you want to answer now.
No, sí,
Vale. ¿Y qué hubiera sugerido la radioterapia antes que la cabergolina, después de la segunda cirugía? Y la tercera pregunta, ¿considerarías necesario realizar test genéticos en este paciente con el diagnóstico del adenoma pituitario a la edad de 14 años?
Okay, then. Okay. So I think, thank you for this. It's a very interesting case. Anaphase in young, in children or adolescents, as we all know, are very rare. Can I ask a couple of questions first before we go through the discussion? We have the patient who had the operation in 2009, and then we have a scan in 2012, which showed a significant tumor there, which had grown. Out of curiosity, did we have any scans between 9 and 12 showing growth, or he had scans and no growth was detected, and all of a sudden the tumor just went up to this size? Any idea, unless he was followed up in another hospital, which can happen, and then we miss the continuity?
Now, we don't have any scans before 2009 and 2012.
Okay, so in 2012 we come, we come with this large tumor. Can we go, if you don't mind, if you could share screen and you could show us the latest scans, this beautiful slide that you had with all the scans? Okay. I will tell you how I would have approached this case, and there is no right or wrong, because quite often we are judged by the final outcome rather than the diagnostic or therapeutic process we have. First of all, I would stop the cabergoline. It's a young man who is on 6 milligrams per week, which is a very large dose for someone to go on for years and years. And it seems that cabergoline hasn't offered a major benefit unless if the case was that without cabergoline, the tumor would grow more and more and more than what has done until now. So I would stop the cabergoline. Then, thankfully, vision is okay. I would have two options. One is to monitor, and from the moment I picked up growth, I would go for surgery, debulking, followed by radiotherapy. Or radiotherapy, but radiotherapy I would go with stereotactic fractionated. Yes, the tumor is close to the chiasm. You can speak with the oncologist, with the colleague who is in your country is offering the radiotherapy, and ask them if they could consider stereotactic fractionated, which still has risks. And this tumor obviously is not the best tumor to approach, even with this type of radiotherapy. If your oncologist says no, then I would definitely advocate repeat surgery. And I would have preferred if after the second surgery, which was in 2000 and I mean, we have the scan of 2014, for example, I would have liked my surgeon to have been more aggressive with that surgery, remove more tumor. There is still intracellular tumor. It's not in the cavernous sinus, so I would like this to be debunked. So in summary, I would stop cabergoline, monitor, and if there is growth, go for surgery plus radiotherapy. Or I would even ask my surgeon now to debulk the tumor, monitor, and if the tumor starts growing, I would consider radiotherapy.
Nikki?
Yeah?
Karina again. We have the history. We didn't follow the patient, but what we observed was that when the patient in the first surgery, there was almost higher than 50% resection, and then the tumor grew, and so he had the second surgery. Since the second surgery, the tumor hasn't grown again, it's stable, and he's in under cabergoline. So I received a patient under cabergoline, and my question is, why is the reason after the second surgery the tumor didn't grow? Isn't the effect of cabergoline, and that is why I didn't take off cabergoline.
Yeah, sure. I mean, I understand the concept. My concern is that, yes, we are talking about the cabergoline and the positive effects or whatever they are on stopping the regrowth of Anaphase. But a concern with this boy is that he's on 6 milligrams per week, and he has a life expectancy, hopefully, of decades. So are we going to leave him on cabergoline for the years and years to come? I think one day we will cross the pathway that we will have to take a decision on that.
Yes, that's why we thought about radiotherapy, but we found the radiotherapist saying that due to the proximity to the chiasm, he couldn't do stereotactic radiotherapy. So the question is, that is wrong, no? In your opinion, it's not...
No, I'm not saying it's wrong, but I know oncologists can be a little bit jittery with this type of tumors. If your oncologist is adamant that he or she does not want to offer radiotherapy, which is justified, then you draw a line, and what I would do is I would monitor. If there is further growth, I would offer an operation, or I would offer an operation even now, because we need to debulk this tumor from there. The chances that the tumor will reduce in size in the years to come are not, of course, zero. There is a minimum chance that the tumor shrinks, but the behavior of the tumor has shown that it will most likely will continue growing. And I hear the point that maybe cabergoline does the job and stops the tumor from growing further, but still we don't know. And again, we cannot keep this boy on 6 milligrams per week forever.
Yes. Okay.
Were your surgeons happy to reoperate? It's a tumor on the plate.
We have suggested him surgery before the pandemic, but it was postponed, and so he's waiting. He feels well. He has no pituitary dysfunction. He has normal visual field. Radiotherapy said no, so we decided to operate him due to the high doses of cabergoline, but he's still waiting due to COVID.
Yeah, so it is an option. It is an option, and if you operate on him, the worst that can happen is that he becomes hypopit, which, I mean, further he's on pyroxene, but thankfully nowadays management of hypopituitarism is easier, I would have thought. It's not as it was 30 years ago. Because by debulking the tumor, you buy years for him. You buy years. And as with some data we showed on behavior of regrown tumors, if a tumor has started growing, the possibility that it will continue growing if we just monitor, it's relatively high. And importantly, this is a young man. He has a long life expectancy.
Okay, perfect. Sí, nomás. Another question? No, we asked you about genetic tests for when do you make genetic?
Yes, I mean, obviously the possibility that there is a mutation there that could relate with the tumor is very low. We know that AIP pickup rate mutation pickup rate in Anaphase is very, very small, but I would, in Birmingham, we have the policy of doing that. I would check his calcium as well. Possibility of MEN1 is very low again, but we would do AIP and MEN1 genes.
Okay, yeah. It's normal calcium. The age to ask for AIP is 30, less than 30 for you there?
We use usually less than 30, yeah. But I think that as time passes with more and more data coming, probably age limits will change. It's like with the pheochromocytomas, you know, when I was in medical school, we had this rule of 10% of whatever. And now in PHEOS, we practically test every patient for genetic testing. I'm not saying that pheochromocytomas are the same as pituitary adenomas, but yeah, at the moment we are using 30, and we will see in the years to come if this cutoff changes.
Okay, we go. Any other question in this room? No, we go to the next case. An incidentaloma.
Un paciente de 50 años con diagnóstico de incidentaloma hipoficiario, con antecedentes personales de hipotiroidismo desde 2012, un prolapso de válvula mitral en 2014 y es alérgica a la penicilina. La menarca desde los 12 años, ciclos menstruales regulares hasta los 48, oligomenorrea desde enero del 2019 y amenorrea desde febrero del 2020. 2 embarazos sin complicaciones, sin antecedentes familiares de relevancia. En marzo del 2018 inicia con paresthesis en la región occipital, sin otro signo o síntoma neurológico. Le solicita una resonancia de encéfalo, donde en la región celar se ve un hallazgo, un incidentaloma celar, una lesión quística. Esta lesión medía 12 por 13 por 15 en su diámetro máximo. No tenemos el corte de la imagen del T2, pero en el informe tenía una imagen hiperintensa de características de líquido quístico que contactaba el quiasma óptico impactando sobre este. En el corte sagital. No tenemos campo visual de esta fecha y en este momento ya tenía una función pituitaria normal. Ella fue evaluada desde el inicio en otro centro, donde tomaron una conducta expectante en este primer momento. Durante el seguimiento en el otro centro, tiene una resonancia de julio del 2019 con la lesión quística de diámetros similares, 15 por 12 por 8, que presentaba contacto mínimo con el quiasma óptico, pero el mismo tenía señal conservada. Pese a esto, presentaba compromiso en el campo visual de junio del 2019 con una cuadrantopsia superior derecha. El OCT era normal y tenía una función pituitaria normal, una reserva hipoficiaria normal. Acá la lesión en el T2, donde medía 15 por 12. En este momento nosotros conocemos a la paciente a finales del 2019 con estos estudios. Y la pregunta era, ¿cuál sería el mejor tratamiento o la mejor conducta en frente de una paciente con una lesión celar quística mayor a 10 milímetros en contacto con el quiasma óptico con una cuadrantopsia, pero con función hipoficiaria normal? Sí. Dr. Nikki, we want to ask to you this question. What will we do with the best treatment in front of this patient?
For this patient, I mean, first of all, we have to think of what the differential diagnosis would be. To me, the differential diagnosis mainly is between a Rathke's cleft cyst or a purely cystic craniopharyngioma. A purely cystic adenoma is, I would have thought, a rare scenario, but I would go mainly for Rathke's. So coming back to your question, she's now, what's her age now at the time that we are discussing?
50.
50. Okay, and the tumor is in contact with the optic chiasm. She has quadrantanopia. Of course, she has normal pituitary function. There are various options here. One is to continue the monitoring. It is a cystic tumor. It may regress. Rarely, it can happen. Or to offer her surgery, given the quadrantanopia, and mainly go for a cyst fluid aspiration, because probably complete removal of this lesion would be difficult to remove the whole cyst wall. These are the two options. I would discuss them with her, and we see what she wants.
We suggest the surgery. Nosotros sí sugerimos la conducta quirúrgica. Fue evaluada por neurocirugía y en contexto de la paciente la indicación era la cirugía. Durante el seguimiento, en contexto de pandemia, perdió el turno quirúrgico y la cirugía no se llevó a cabo. Ella retorna en enero del 2021 con una nueva imagen celar de octubre del 2020, donde había una disminución espontánea de la lesión quística. En este momento medía 10 milímetros en su diámetro máximo, tenía contenido quístico y respetaba tanto el quiasma óptico como el tallo hipoficiario. El campo visual, que era normal, el OCT de octubre del 2020 también normal, una función pituitaria conservada en ese momento, sin hallazgos al examen físico, y la paciente refería a una galactorrea de hace 10 años que venía en franca mejoría los últimos meses. No tenía secreción espontánea, no tenía dolor de cefalea ni alteraciones visuales o poliuria. Sí. Dr. Nikki, we want to ask to you, what do you think is the most likely diagnosis?
Yeah, I think we covered it more or less previously. First, on the first shelf for me would be Rathke's cleft cyst. And then, as I said, a purely cystic craniopharyngioma, and the very, very remote possibility, very remote, of a cystic adenoma. But most likely to me, it seems like a Rathke's cleft cyst. Now, coming to your second question, is it frequent of spontaneous tumor shrinkage? I can't tell you if it is frequent. Of course, we have data, published data, which can be biased because there are selected patients. It can happen. How common it is, I'm not sure. I can give you various percentages, but I don't know how they reflect the truth. It can happen. And this is usually an imbalance between fluid secretion and absorption, or rarely it may be intermittent fluid leakage around the tumor. Usually it's an imbalance between absorption and secretion. It can happen. We've seen that. We've come across such cases too.
They are asking here if you have any experience, if the tumor had remained stable, of instilling any substance in the cystic in order to during surgery.
Well, I haven't got personal experience. There is, as far as I can recall, for Rathke's, there is some literature on alcohol instillation, but data are not exciting, and there's always a risk of toxicity in the surrounding area. And of course, for and this literature comes for craniopharyngiomas, instillation of various other substances, or even radioisotopes. The risk of toxicities is there, especially if we install radioisotopes. But for Rathke's, apart from the alcohol instillation, I'm not aware of anything else. And as I mentioned, I don't have any personal experience on that. And I doubt if many people around the world would have experience on that, because usually we aspirate the cyst or we remove part of the wall, and that's how we manage it.
Okay. Any other question? We have a third case of Cushing, so we go ahead with the third case. This case made us learn that the lesions can regress. We were very much surprised when we saw the regression, the spontaneous regression. So
Yeah.
consideration.
Can you see the slides sharing?
El último caso, voy a presentar una paciente femenina de 54 años de edad con enfermedad de Cushing, en seguimiento desde 1994 como antecedente de la enfermedad. En 1991 se le realiza el diagnóstico de Cushing durante el embarazo por características fisonómicas, hipertensión y diabetes. En 1992 se realiza la cirugía esfenoidal a 6 meses posparto. Esta es la primera imagen con la que contamos de 1991 prequirúrgica, con una inmunohistoquímica postquirúrgica que con celularidad positiva para ACTH en un 50-60% de las células y un KI67 de 6.1. Como déficit postquirúrgico quedó la paciente con un déficit gonadotropo y somatotropo. Esta es la evolución imagenológica preembarazo, durante el embarazo, posembarazo y postquirúrgico. En 1994, por persistencia de la enfermedad, se realiza una segunda cirugía transesfenoidal, porque no contamos con inmunohistoquímica, más 10 sesiones de radioterapia, más el uso de ketoconazol, que se desconoce el tiempo de uso y la dosis. Siempre la paciente tuvo campos visuales normales. Este es el remanente postquirúrgico de 1994 que se reoperó, y nosotros iniciamos el seguimiento en el 2014 en el servicio. En la parte bioquímica del 2014 vimos que tenía un CLU elevado, un UN que no suprimía y alteración del ritmo circadiano, por lo cual en el 2015 se inició cabergolina en dosis ascendente hasta 1.5 miligramos por semana, que se discontinuó al año de tratamiento por intolerancia gastrointestinal. En el 2016, a 20 años por radioterapia, la paciente no tenía síntomas, presentaba un CLU normal y no tenía impacto óseo, por lo cual se decidió medidas expectantes. En el 2019, a 21 años por radioterapia, ella inicia con síntomas de insuficiencia adrenal, por lo cual se le realiza un laboratorio que presentaba un CLU y un cortisol bajo y un UENT que no suprimía. Inició tratamiento con hidrocortisona 10 y 5 miligramos. Posteriormente, en el 2020, ella refería síntomas similares a los que presentaba cuando tenía la enfermedad de Cushing. Había aumentado de peso aproximadamente 15 kilogramos y presentaba edema en miembros inferiores. Presentaba una bioquímica con un CLU normal bajo tratamiento, el NUENT que no suprimía y un cortisol bajo, por lo cual continúa en tratamiento con hidrocortisona, y se le realizó el cortisol en cabello que presentaba 262 por arriba del límite superior de lo normal. Como antecedentes de la paciente, ella tiene glaucoma, diabetes tipo 2 insulino requiriente, tuvo colecistitis, es fumadora actual de 17 paquetes año, como antecedentes ginecobstétricos, tiene la menarca a los 12 años, ella está en amenorrea desde los 24 años y declinó por el uso de reemplazo de terapia hormonal, tuvo 2 partos, un aborto inducido y un parto normal, y actualmente está bajo hidrocortisona 15 miligramos por día, metformina, vidaglitina 2 veces por día, rosuvastatina 20 miligramos por día, insulina de Gludec como basal 30 unidades más sus correcciones con glulicine, omeprazol 20 miligramos por día, losartán 50 miligramos por día, pregabalina 75 miligramos, alprazolam 0,5 miligramos por día y travoprost unas gotas oculares. En el examen físico actual, ella está normotensa, con un BMI de 46, presenta obesidad central, con estrías blanquecinas a nivel abdominal, jiba dorsal, y tiene huecos supraclaviculares ocupados con un edema bilateral en ambos miembros inferiores. No se evidenciaba miopatía ni poliuria. Dentro de la evolución bioquímica que se hace desde el 2014 cuando inicia su seguimiento en el hospital, tiene un perfil tiroideo en toda su evolución normal, se evidencia el déficit postquirúrgico primario del déficit gonadotropo y somatotropo, pero a partir del 2015, en contexto de un CLU elevado, el NUENT que no suprimía y la alteración del ritmo circadiano, Como ya habíamos mencionado, inicia cabergolina, que se descontinuó por intolerancia gastrointestinal. En el 2016, con un cortisol de 8.3, se le realiza un test de Sinastent con un cortisol post-estímulo de 26.1, por lo cual siguen en control evolutivo, y en el 2019, en contexto de los síntomas, un CLU bajo y un cortisol bajo, inicia el tratamiento con hidrocortisona. Entonces, la paciente presenta 3 déficits, el gonadotropo y el somatotropo postquirúrgico, y postrradioterápico el corticotropo. A pesar de estos 3 déficits, continúa la paciente con el NUGEN que no suprime, la alteración del ritmo circadiano y el cortisol bajo. Dentro de la evaluación imagenológica, tiene una resonancia de 1992 con un macroadenoma hipofisario de 17 por 12 milímetros, un OPS2, un HARDI2, que en el postquirúrgico quedó con una lesión heterogénea mixta, y posteriormente con la lesión a nivel celular supracelular, pero que contactaba el quiasma óptico, pero sin alteración del campo visual. Con esta última imagen de 94 se reoperó, y la imagen postquirúrgica de la segunda operación es igual, con una imagen heterogénea con realce periférico, que para el control del 2015 persistía la imagen, pero con menos realce periférico. Nosotros no contamos con la última imagen del 2020, que es posterior a 26 años posteriores a la radioterapia, pero en el informe evidencia una lesión heterogénea hiperintensa en T2 a nivel del tallo pituitario. Dentro de los impactos de la enfermedad, ella tiene diabetes diagnosticada en el 1991 durante el embarazo. En el posparto quedó con terapia oral con hipoglucemiantes, y a partir del 2016 inició con insulina, que actualmente está con una hemoglobina glicosilada de 6.8 bajo insulina basal de 30 unidades de Gludec asociada a medicación bioral biterapia. En contexto de la hipertensión se diagnosticó en el 2019, pero recordemos que ella tenía preeclampsia en el embarazo. Actualmente sus presiones están controladas bajo una droga, y dentro de la salud ósea ella presenta una densitometría normal, no tiene antecedentes de fracturas, y está reemplazada con el consumo de calcio en lácteo de 500 miligramos más vitamina D 100.000 unidades mensuales.
¿Cómo interpretaría la presencia de NUGEN alterado y alteración del ritmo circadiano en un paciente con valores normales o bajos de cortisol urinario? ¿Y consideraría que este paciente está en remisión? Los pacientes con cortisol urinario normales y un ritmo circadiano alterado o una respuesta inadecuada al test de NUGEN tienen la misma morbimortalidad que los pacientes con valores de CLU elevados y bajo reemplazo con hidrocortisona. ¿Y cuál sería su interpretación acerca de las imágenes celares?
Interesting case, amazing case, which shows us how much we all learn every day from Cushing's patients. Just to ask a question, we offered her hydrocortisone in 2019, if I remember well. Did she have, I remember a random or morning cortisol value. Did she have a short synactant test at that time? She had one in 16, I believe, which was okay. But in 2019, before she starts the hydrocortisone, did she have a short synactant test?
Synactants have been taken out from the country, so we are not able anymore to do synactant in Argentina.
Oh, really?
So we have to rely on the serum cortisol.
We are just waiting for it.
Oh, that's very interesting. Okay, so practically we don't know if she truly had adrenal insufficiency. We relied on her clinical picture plus the random cortisol. Yeah, if I got it right. Okay.
Yes.
I mean, yeah, my feeling, which I don't think it's just a feeling. I mean, looking at the patient, clinically she looks Cushingoid, no doubt. Biochemically, I think her biochemistry points towards Cushing's there. I don't think this woman is in remission. Now she has normal 24-hour urine-free cortisol or not high 24-hour urine-free cortisol, and late salivary cortisol is high. And nugget, does it mean dexamethasone suppression test?
Yes, 1 milligram.
Ah,
Yes,
okay. Yeah. How do you call it? Nugget? Nugget?
Nugget test.
Okay, I said nugget, sorry. So we do come across cases in which the 24-hour urine-free cortisol is normal and the other test points towards direction of Cushing's. And 24-hour urine-free cortisol is not the best test to diagnose Cushing's or even recurrence of the Cushing's compared with other tests, the other available tests. So my feeling is that this lady does have active Cushing's. I'm not sure if I would keep her on hydrocortisone unless she has cyclical Cushing's and she cycles. She comes in and out, and there are periods that she, when the Cushing's is not active, that she has symptoms of adrenal insufficiency. This is something I can't comment on really, but definitely she has active Cushing's. Whether it cycles, whether it is continuous, something we could discuss. I can see a tumor there in the stalk. Could a surgeon go there and remove it? I doubt if a surgeon would be able to have complete removal without consequences. Another point is that, and probably you don't have this data, she had radiotherapy in 1990 something, and we say 10 sessions, is that correct? So do we know what kind of radiotherapy? Because usually this is either fractionated, is spread in 20, 21 sessions or more. 20. So do we know that, why am I asking, was this radiotherapy good enough or had it to be stopped for whatever reasons? So coming back to the query, did she really have appropriate radiotherapy? And coming back to how we could deal with this patient, it's a dilemma here. She has active Cushing's. I don't think that surgery would be an option. So either we would go with medical treatment and block and replace regime because she feels unwell and things fluctuate. Do you have metyrapone in Argentina?
No, we don't. We have ketoconazole.
Pardon?
But
Only
ketoconazole.
Only
The
ketoconazole.
question is, if she has a serum cortisol that is persistently in the lowest range, below the low range. A UFC of 11 without replacement, low also. Clinical of adrenal insufficiency. So I really have many doubts of taking out hydrocortisone. And the question is, it is described that after surgery and especially radiotherapy, you can still have the loss of the circadian rhythm. And does that mean that she is active as a UFC of 4 times higher? That is the doubt we have.
I share your doubts. I share your doubts. However, the clinical picture of this patient and all the comorbidities she has and all the medications she's on make me think that it is likely that the disease is still active. Now, I think we have to look at the dynamics of the cortisol secretion here. And we don't know how the dynamics of the cortisol, of the HPA axis has evolved over the years. We have a patient who definitely looks Cushingoid. We have the late night salivary cortisol, if I got it right, which is not as it should be. We have the overnight dexamethasone suppression test in which she does not suppress. So I'm more tempted to believe that this woman has Cushing's, and whether the activity fluctuates, so it is cyclical and she comes in and out, and that's why she may need hydrocortisone, or we pick up a cortisol, morning cortisol of that value. But I'm not convinced that she doesn't have Cushing's. And we have a pituitary lesion, which of course we don't know how active it is, but we have something extra. I think in these cases here, we would put them in a block and replace regime, and I understand the limitations. Metyrapone is not available in Argentina. You could try ketoconazole and hydrocortisone. You could consider which is a bit of a dilemma here, bilateral adrenalectomy, but she has a lump there in the pituitary, so there is a risk of Nelson's. Or you could consider irradiating her again, the pituitary, because she had the radiotherapy 25 years ago. Okay, she had these 10 fractions, which we don't know what kind of radiotherapy it was. In 1994, was gamma knife available, or cyber knife, or whatever? I mean, cyber knife would be hypofractionated, which could justify the 10 fractions. But what kind of fractions were there? Obviously, gamma knife would be 1 fraction, so it's not that this is what she had. So I would consider as another solution re-radiation and wait, or bilateral adrenalectomy, and I'm very anxious about that, or a block and replace regime. And the block and replace regime would keep her stable. So we knock out any cortisol secretion that she may have, and then we offer her the regular replacement. Now, how do we monitor her with a block and replace regime? There is a lot of discussion here, and I'm not sure that we have reliable markers, but clinical picture would be useful, plus whatever we can do in biochemistry. I think it's very challenging. This is a very challenging case. Very challenging.
Yes. I have great doubts about sufficiency and going ahead in. I know, because metabolic syndrome, it's an issue in a postmenopausal woman. The face, and perhaps hypertension and diabetes, she had it before due to family history or whatever. I'm trying to arrange this. Do you think it will be useful to do a hypoglycemia? That because we do not have a synaptin. And so in order to really say if she is adrenal sufficient or not, to do an hypoglycemia as a test of
ITT, insulin tolerance test. Yeah. She would require good supervision.
Yes,
I don't know if I don't know if she has ischemic heart disease. No. Or what you could do, why don't you do something else? Why don't you go with a glucagon test? And we know the limitations of the glucagon test. We know it's not the best test, but at least you could have something to start with.
Okay, glucagon test. Yes, in order to get the adrenal sufficiency.
I wish we could send you synactin from here. I mean, this would solve solve the problem. And there is no way you can get synactin from any country around, just for her, any area around.
Well, we'll try, but I don't think so. We have a porcines, an ACT8 derivative that is porcine.
Of
ataxia.
Okay, all right. Okay, we don't want that. I guess. I mean, a short synactin would give a good solution. I would try, you could do an ITT, or on the first instance, I would go for a glucagon test, knowing its limitations. What can we do? I mean, wherever we are, we manage our patients with whatever is available at that time. And but she's very interesting. I mean, to me, I hear about the metabolic syndrome, and of course, this could play there. But in a patient who had Cushing's, who we know that she didn't go into remission, and then many, many years later, she appears with adrenal insufficiency, or what we think is adrenal insufficiency, having radiotherapy of only 10 fractions, and not having other, I don't know, I mean, it's a dilemma.
They are asking about DHEA as a marker of adrenal insufficiency, and they tell me that it's low, but she's now on in the 50s, so probably perhaps it's low because of age. But, well, yeah. Nikki, very, very interesting your view. I was not able to imagine hypercortisolic or Cushing with UFC, absolutely normal, but.
Well, I'll give you an example. A patient recently we had who was referred to us by a local physician in one of the local district hospitals, who looked Cushingoid, and more or less like the lady you showed me. And she's diabetic as well. And he was looking after her for her diabetes. And he said, oh, it may be Cushing's there as well. So he did a low dose on overnight first, and dexamethasone suppression test, and then a low dose dexamethasone suppression test in which the cortisol went to 60, 65. So if we divide it by 30, it is 2 or something with the units that you would describe. A 24-hour urine-free cortisol, which our cutoff is 130, it was 150, okay. And late salivary cortisols we did not do because she presented in the COVID pandemic and we couldn't do salivary samples. I saw her. Clinically, she looked Cushingoid, but these results were so iffy. Just to add that the colleague did a pituitary MRI for her as well, and she had what seemed to be a macroadenoma, which was causing compression of the optic nerve, and she had visual deterioration. So when I saw her, I said, but okay, she looks Cushingoid, but what about metabolic syndrome? So my thoughts were like yours. And I said, maybe this is the stress she's on. She has bronchiectasis as well, so chest issues. What if it's the stress that she's on and she does not suppress on the dexamethasone and this iffy 24-hour urine-free cortisol? But we decided to operate on her because of the visual deterioration, okay? And it was a corticotroph adenoma. And post-operatively, and it was an adenoma that could be removed completely, she had undetectable cortisol. And after that, I said, oh my God, I think I know nothing about Cushing's. So I mean, presentation is all over the place, I think.
Okay, Nikki. Thanks very much
Thank
for
you.
sharing your knowledge and experience. I think it was great for all of us. It was a pleasure.
Thank you. Yeah, thank you very much for joining us.
Thank you.
Well,
Thank you very much for inviting me. I wish all the best to all of you, and it's lovely, a great pleasure to meet you all and interact with you on the internet. Hopefully, meet face to face soon.
Thanks very much for spending your time with us. We know you're very busy, and we hope next time face to face in Argentina. So you're welcome. Okay.
Okay. Take care, everybody. Thank you for your time. Thank you for inviting me. Thank you.